All right, today we're jumping into a big one, heart failure with preserved ejection fraction, or as we all know it, HFpEF. For years, this condition was just a massive puzzle for cardiologists, both to diagnose and to treat. But wow, the landscape has changed. So this is your clear, high-yield update on exactly how to manage this complex condition today. So here's our game plan. We'll kick things off by making sure we're all on the same page about what HFpEF actually is. Then we'll get into the exciting stuff, the new cornerstone of therapy, SGLT2 inhibitors. After that, we'll talk about managing fluid, some conditional therapies, and then wrap up by going after the root causes, and, just as critical, what not to do.
So, first things first, you gotta know your enemy to defeat your enemy. What exactly is HFpEF?
Okay, so HFpEF is really a clinical syndrome. The heart's squeezing function, its ejection fraction, is totally fine. It's 50% or more. But despite that, patients get all the classic heart failure symptoms, shortness of breath, swelling, the works. The key, the thing you have to prove, is that there's real objective evidence of high filling pressures inside that left ventricle. So you're probably thinking, if the heart is squeezing just fine, what's the deal? Well, the problem isn't the squeeze, it's the relaxation. The best way to think about it is that the left ventricle is a stiff, non-compliant chamber. It just can't relax and fill up with blood the way it's supposed to. That failure to relax causes pressure to back up into the lungs and, well, everywhere else. That stiffness is the central problem we're trying to fix. Now let's get to the most exciting update in a generation. I mean it. For the first time ever, we have a true foundational pillar of therapy for HFpEF that's been proven again and again in major randomized trials. And here they are, the SGLT2 inhibitors. You've heard the names, Empagliflozin and Dapagliflozin. These are now, without a doubt, the standard of care. And this isn't just a hunch. It's backed by two absolute landmark trials, Emperor Preserved and Deliver. These studies made it crystal clear, for symptomatic HFpEF patients, this drug class is where we start. And the results speak for themselves. A meta-analysis of these huge trials showed about a 25% relative risk reduction in the primary outcome. And that was almost entirely driven by a drop in heart failure hospitalizations. I mean, that's a massive win for our patients. It keeps them out of the hospital, feeling better. It's a game changer. Now, SGLT2 inhibitors are the foundation, for sure. But we also have to deal with the most common and miserable symptom of HFpEF, and that's fluid overload, congestion. This is where loop diuretics come in. They are absolutely essential for making patients feel better because they get that excess fluid off. But, and this is a big but, you have to be careful. That stiff ventricle we talked about, it's super sensitive to preload, the amount of blood filling it up. If you pull off too much fluid too fast, you can cause low blood pressure and hurt the kidneys. So the mantra always is start low and go slow. Okay. So beyond our pillar therapy and diuretics, we've got some reinforcements we can call in for specific patients. Think of these as our conditional therapies, MRAs and ARNIs. The story behind MRA therapy is actually pretty interesting. The big trial TopCat was just fascinating. When they broke down the data by region, they found that spironolactone worked. It reduced heart failure hospitalizations, but only in patients from the Americas. In the group from Russia and Georgia, there was no benefit at all. This has made people wonder if maybe the diagnosis or adherence was different in that group, which makes MRAs a totally reasonable option, especially for the right patient here in the States. Next up, we have the ARNI, sacubitril valsartan. Its major trial, Paragon-HF, technically just missed its primary endpoint. I mean, it was so close. But when the investigators dug into the data, they found some really important signals. It looked like there was a real benefit, particularly in women and in patients who are on the lower end of that preserved EF spectrum. So let's say an EF under 57%. Using all these drugs is really just one part of the battle. HFpEF almost never happens on its own. So to truly get a handle on it, we have to get aggressive and address the other conditions that are actually driving the disease. And these are the four main culprits right here. Hypertension, that's the #1 driver of that ventricular stiffness. Atrial fibrillation can be a disaster because these stiff hearts really depend on that final atrial kick to fill up. Coronary artery disease can make the diastolic function even worse. And of course, obesity is a huge player in a massive subset of these patients. Let's actually zoom in on that last one, because the connection between being overweight and having HFpEF is just so important. And it really points to a big shift in how we're starting to think about treating this disease. This is another huge development. the GLP-1 receptor agonists. For our patients who have both HFpEF and obesity, which we define as a BMI of 30 or higher, drugs like semaglutide are showing absolutely remarkable benefits. They seem to target the metabolic inflammation that really drives this specific type of HFpEF.
And the data from trials like STEP-HFpEF is just striking. Yeah, these drugs lead to significant weight loss, but they do so much more than that. Patients tell us they feel dramatically better, their quality of life improves, and we see a real, meaningful reduction in heart failure events. This is what we mean when we talk about phenotype-specific therapy. It's here.
All right, let's wrap this all up with something that's just as important as knowing what to do, and that's knowing what not to do. These are the therapies that have been put to the test in HFpEF and have, well, failed. First up, nitrates. The NEHFpEF trial showed they don't actually help with symptoms and might even make people less active. Second, digoxin. An analysis of the old DIG trial showed no benefit at all on mortality or hospitalizations in HFpEF. And finally, drugs like sildenafil, those phosphodiesterase 5 inhibitors, also no benefit. So using these to treat HFpEF itself is just not based on evidence. So, if you're going to boil all this down into one simple, actionable playbook, this is it. SGLT2 inhibitors for basically all your symptomatic patients. Diuretics when they need them per volume. You can consider MRIs or an ARNI for a few carefully chosen patients, and the foundation of everything, you have to treat those root cause comorbidities, and you have to treat them aggressively.
And that leaves us with one last kind of provocative thought. For so many years, we've treated HFpEF like it's this one single disease. But as we're seeing with the incredible success of GLP-1 agonists in the obesity phenotype, the future probably isn't about finding one magic bullet for everybody. It's about figuring out the underlying driver in each patient and targeting that. It's a fundamental shift from just treating the syndrome to actually treating the cause.